Hi, I'm Professor Gazzard. I'm the Clinical Research Director here and started the unit in about 1982 or 3. We have currently, I would think, about 8,000 patients, of whom about 6,000 are on treatment. We've seen about 25 or 30,000 patients in my lifetime. So I think research has always been fairly broadly based here, primarily directed towards improvement in patient care. So we've been heavily involved in all the antiretroviral research in terms of drugs that have really ever been conducted. We've always had a special interest in immunology and the immunological changes in HIV, which of course has led to a fairly busy vaccine program here. Now, I suppose, like most people, we're interested potentially in cure, although I think that's a pretty distant prospect. We also have a fairly well-defined international arm where we do a lot of teaching abroad. I think HIV therapy is an enormous success story. When you think that in 1981, I was telling all the patients they would die, but we'd try and make sure that was with dignity and without any pain. And we're now telling people you will all survive long-term, providing you take some pills. That's a miracle, really. Of course, not everybody is successfully treated for their lifetime. The primary reason, of course, is twofold. One, that people don't know they're HIV positive and so are treated very late and will therefore still die of the effects of the very suppressed immune system. And secondly, there are a proportion of people who just won't take treatment. And I think, interestingly, perhaps that's the most important avenue of research that there is. These people continue to spread the epidemic and continue to die because they won't take the treatment that's offered. Yes, of course, people do sometimes fail when they're actually taking treatment. Undoubtedly, very much the commonest reason for that is they don't adhere properly to their medication. The number of people who fail, who are totally adherent to the medication, is virtually zero. Always very difficult to say zero, but virtually zero. When people don't take their drugs, one of two things happens. Either they don't take any of the drugs, in which case usually the virus reappears in the circulation pretty quickly and is sensitive to all the drugs that it was sensitive to before. Perhaps less commonly, people take bits of the treatment but not other bits. And of course, when that happens, there's a considerable tendency for the bits of treatment they do take, for the virus to develop resistance to that and to remain sensitive to the bits of treatment they've stopped. So it's a bit variable. I would think of the two, the commoner situation is to remain sensitive to the drugs that you just stopped. Clearly, there are two issues involved in that. One, if you only have one pill once a day, then you either take it or you don't. So probably resistance is less of a problem in that group. And clearly, if you have drugs with very different half-lives, then you will continue to be exposed to one or two drugs if you stop treatment that may lead to resistance to one of those drugs. Obviously, the measurement of adherence is itself quite a major problem. You can ask the patient, they tend to be nice to the doctor. You can ask them to feed into a computer whether they take all their pills when they're more relaxed and tell you a more honest picture. However, I think the main mechanism is still, if you're virologically undetectable, you are taking enough treatment to control the virus. So we use the viral load as a surrogate marker really quite widely for adherence. If you see a patient and their viral load becomes positive, one, you immediately do a resistance test. That, in a sense, goes without saying. You secondly immediately say, are you taking all your pills properly? Are you taking all your pills? We can, of course, do plasma levels of the drugs to try and ensure whether they are taking the right amounts of drug at the right sort of time and that there aren't other drugs interfering with the absorption of the particular drug. So it's a multi-pronged approach. To resuppress the virus in somebody where their virus load is raised, we use resistance tests. And these resistance tests will help us very strongly to predict which drugs will work subsequently. I think all of us use standard genotypic testing as the first line of deciding whether resistance has occurred. This resistance testing is taking a very small sample of a very large virus pool and hoping that that is representative of the overall pool. And of course, sometimes it's not. And so if there is within the pool minor variants which are resistant to the drug, these could become the predominant resistant variety if you then give the wrong drug combination. So in resource-limited settings, the major challenges are, of course, lack of money and a very, very large epidemic. So to deal with that, we need to rethink, one, how we medicalize the giving of drugs, and perhaps we should demedicalize it. Secondly, how we provide accurate tests at the bedside so that the person needn't travel to and from continuously, but we are certain whether or not the present treatment is working. And thirdly, of course, the whole panoply of treatments are just not available in some developing countries, and they're going to be needed if we're going to keep people alive really long term. The strategy in the developing world at the moment is ever-changing, but I think the first thing to say is that one of the things that we perhaps should be doing is a much more test and treat policy. That at the moment, you have an HIV test and you then have a CD4 count, you have to come for the result, you're very often told to wait several years, and the rate of non-attendance, because of transport costs, etc., is very high. So one of the things that we could do to really change that will be to say, you're HIV positive, you should be treated. Very successfully done, of course, now in Malawi. If you're a pregnant woman and you're HIV positive, you get treatment, and you get treatment long term, and you never know what your CD4 count is. So that's one approach. The second approach, of course, as we've discussed already, would be to make bedside testing both cheap and feasible. And what RDI and other people are trying to do, of course, is making such testing cheaper, more reliable, and more robust, of course. So I think RDI play an important role in trying to give algorithms of care so that they can predict from simple data what subsequent drugs are likely to work. And of course, it's always been the case, hasn't it, that computers do better than the human mind when we try and do that. So I always use the rather trite example of chest pain. We all think we're very good at diagnosing when you've had a heart attack. Actually, a computer is always better. So a computer designed with a learning capacity within it will predict better for us in due course which treatments will work when the first treatment has failed. We've had a long-term collaboration with the RDI. We've admired the way in which the RDI is set up as a charity and wants to improve outcomes, not on the basis of profit, but on the basis of, what's good for humankind. And so we have used our quite extensive repository and our extensive knowledge of drugs both before treatment and what the response is after treatment to try and improve, with lots of other people, of course, the RDI computer system to give better predictions of outcome. The accuracy is pretty good, so it's 80%. So 80% you'll get it right next time round. I was at the resistance meeting, which we have regularly yesterday, and it's of course increasingly complicated, and there is I dealing with it every day. I can't really remember every single mutation, particularly when it's a different amino acid from the normal one that's mutated, as to what effect that will have. And there a computer would be ideally suited to actually telling us more accurately than I can remember what drug we should use next. So as I think we've said, the RDI system is pretty accurate and is better than any genotype rule-based system. Clearly the problem for all of us is that the genotype rule-based system works in a fairly large majority of people, and it's the difficult ones where we really need help. But why shouldn't we get help with the easy ones as well? So I think that, a system where we could all relax and just plug it into the computer and tell us what to do next would really be ideal. I think one of the great strengths of the RDI model is that anybody can use it. All right. Clearly, most people would believe it would be more accurate to use it if you had a resistance test. But interestingly, the accuracy is very high without a resistance test. So the prediction in the model can really help us just knowing the history and knowing what people have been on before as to what treatments would be best next time round. So it really is a very widely available model, particularly in the third world where resistance testing isn't going to be available probably for some years yet. The good news is that the RDI website is readily available, providing you've got access to the web, and anybody can then use the model. And I think increasingly one of the great advantages for the third world is that the web is very readily available. Obviously, it's always difficult, I think, to predict when technology is going to be most used. My own view would be that throughout most of the developing world, the average patient, the average clinician does not have access to resistance testing. So that's where its chief and immediate value is going to be. So instead of me trying to remember what each study showed, the RDI computer will tell us what predictively is the best treatment to use. So I think that's where it starts. Clearly, we still find it a valuable resource in the developed world where the resistance testing may be quite complicated, and therefore it will have values in both directions. So I think the clinical situation where this system will be of most benefit is, in a sense, self-evident. It will be people failing treatment, won't it? So it'll be people who have a positive viral load, if we know that. If you're using, in the developing world, development of new opportunistic infections as a surrogate for failing initial therapy, I think those will be the situations in which you would want to plug into the computer to tell you what to use next. Well, I think that, as I said earlier in our discussion, we've already had a miracle. I think the next changes will be all fairly small incremental changes. So I think we will begin to learn the sociology, as it were, of why some people can't or won't take treatment, and improve treatments so that they can. So some of it will be side effects, and we can reduce side effects. Secondly, I think in the developing world, we're making great strides in providing care to a wider range of people. I think we need to actually think quite carefully how we manage those people. Is it possible to have them coming to a hospital, or would it be better for a lot more peer groups to be providing treatment and referring only those people who are difficult into some sort of central mechanism? There's a small chance, I think, that cure might be available in the future. I think the major problem I have is that the cure, all the things that are being done for cure at the moment are unbelievably expensive and are really not applicable to the third world. I'm a bit more hopeful about vaccines than I ever was, not in the next 5 years, but I think in the next 5 to 10 years, we are beginning to understand the correlates of protection. And I think also interestingly, the correlates of perhaps enhancement. One of the missed bits of information, I think, is that several of the vaccines may have actually made HIV worse. And so to analyze why that is and make sure the next vaccines don't produce potential enhancement will also be crucial. So I'm a bit more hopeful than that than I was. I'd like to hope that HIV treatment at Chelsea Westminster remains one of the best in the world and will continue to do so. That's a mixture, I think, of the commitment of the staff that we have here, and a health service which is free at the point of access, and a wide variety of other researchers who we interact with, including our RDI, who have, a mindset that wants to improve care continuously. So I think we have a healthy, positive future. I think I've had an absolutely wonderful life. I have to say that I've been one of the luckiest people alive. Not many people can say that they start with a disease that is fatal, and over their career, you turn it into a disease which is entirely manageable and possibly even curable, and an epidemic which may disappear. Wonderful experience.